I would give my right arm to be able to wave a magic wand at this moment and transport all of us collectively to an apartment on Garden Street in Hartford, where Mary lives. Mary is a 68-year-old woman of color who lives in private, decrepit housing on Garden Street in Hartford, as I said, third floor walk-up. Third floor walk-up. Constant plumbing problems, toilet not flushing, toilet overflowing, toilet leaking down to the first floor. Cracks in the wall to see the outside that you can literally see with your own eyes. Insufficient number of garbage cans to accommodate the garbage of the entire apartment building. An absentee landlord who is less than enthusiastic about addressing any of the issues. The hallways are dark, poorly lit. Mary's mail has been stolen from her mailbox on any number of occasions, including her reapplications for Medicaid, food stamps, and other benefits, so that she didn't know that she was missing the appropriate redetermination cycle. That's what I want to tell you about her housing. I told you she's 68. She is beginning to develop respiratory problems, questionably congestive heart failure. She has brittle, unstable diabetes, and as a result of the diabetes, vision problems, problems with her feet. She's been treated for depression. She's on an antidepressant. She has arthritis, particularly in her knees. She is obese, and she is having increased problems with ambulation. There isn't a decent food store anywhere near where Mary lives. You hear the concept of the deserts, the food store deserts. She lives with, forgot to tell you, it's a 2-bedroom apartment. She cares for her 2 teenage grandsons because their mom is incarcerated, their dad is not in the picture. The 2 boys are in high school. One's a junior, one's a freshman. Lots of problems with truancy, absenteeism, failure in the school system. She's completely responsible for those 2 kids. She has a cell phone that has limited minutes. You know how you buy those cell phones where you have only 15 minutes on the cell phone. She doesn't have a car. I'm describing to you one of the 8,000 people who Connecticut Community Care is supporting here in our state of Connecticut on any day of the week. Are they all as challenging as Mary's situation is? No, I'm not saying that. She's a perfect example of what we're talking about here today. Some people would say she's non-compliant with her medications, okay? I would say she has difficulty in adhering to her medication regimen because she can't get the drugs, because she has trouble keeping her Medicaid cycle intact, and because she can't get back and forth to the clinic to get the appropriate prescriptions for the medication. I'm here to tell you that what we need to do for Mary has very little to do with what we stereotypically picture as the health care system. I will tell you very quickly what the 5 interventions are that we are working on most rigorously with Mary. Number 1 is everything that has to do with consumer empowerment. I know we're all sick of hearing the term motivational interviewing. We are trying to coach and work with Mary to be her own advocate. And as our speaker said this morning, that is not an easy thing to do. This is a woman who has been demoralized by the health and the social support system in our country, in our state who is managing the best she can in taking care of those 2 kids, and that is the primary issue of her life. If you ask Mary what her goal is, her goal has very little to do with medication adherence. Her goal has to do with keeping those 2 kids out of trouble, out of jail, and launching them into an appropriate lifestyle where she can be proud and their mom can be proud of their accomplishments. So consumer empowerment, trying to develop local, and this is obviously your role so much more than mine, Gina, developing local advocacy on housing issues. How do we work with these absentee landlords? How do we keep these absentee landlords accountable? I'm not talking about her lab results. I'm not talking about how many visits to her primary care physician. I'm talking about working with Mary on her housing issues. Number 2, next main role, intimate involvement with the school system and intimate involvement with the school social worker and DCF in terms of working for those kids. She is scared to death that summer is right around the corner and those kids don't have summer jobs or summer volunteer work or anything to do for the summer. So working with the school, working with the city of Hartford, working with the community to try to find appropriate summer intervention for those 2 boys. We're working with home care services, a whole variety of home care services. So for obvious examples, we're looking to our licensed home health care providers to provide skilled nursing service to help in teaching Mary, working with Mary on a nutrition plan, on a way for her to better manage her diabetes. We're looking at Meals on Wheels for Mary if she's willing to consider that. We are also working intensely on chronic disease self-management programs, including diabetes self-management that you talked about, transportation, key issue, and finally, working with the criminal justice system so that when Mary's daughter re-enters the community from jail, that she is in a position to assume more responsibility for her 2 teenage sons. So that's just a quick example when we talk about the challenges of the distinction between health and healthcare and how we are going to be supportive of one individual. Mary's an example. I have 5 quick things that I want to say, and Jill just gave me the 2-minute hands up, so I'm conscious that my mic is about to get ripped off my throat. And what I want to say very quickly is this. I think when Jill and Fran asked me to be on this panel, I said to them, I don't know that I'm the best person to be on this panel. I'm not in as optimistic a mood as our first speaker was. I got a few more scars that I'm dealing with right now. So I think that this is what I want to say to you that I see as the 5 challenges. I think we've got some things very right on the individual level, that the individual care managers, care coordinators, navigators, that's part of the problem, obviously, is all these people involved, but I think that we're doing some very good work on that level. I think that the challenges of the system right now are crushing us, are holding us back. I see that in terms of, and again, my colleagues warn me, don't overgeneralize, Molly, when you say this. Also remember your audience. We're having a heck of a time in being included as a serious collaborator with the healthcare systems here in Connecticut. We have hundreds of care managers. I'm just using CCCI as an example. Thousands of clients. We are not considered to be an equal partner in the healthcare system and fight like dogs every day of the week at the individual and the systems level to be included. Number 3, I think we are sorely lacking in our efforts to really address diversity issues. We are seeing and that wasn't talked about specifically today, but we're seeing an extremely diverse group of individuals, that unprecedented in our experience. And so how to understand the cultural ramifications. It's not just about, do you have translators? Yes, we have interpreters. That's not what it's about. It's about the whole cultural landscape for the individuals that we serve. We're challenged by that. I think that we're challenged by a very serious lack of trust. I think many of you, I'm sure, saw the article in the New York Times the week before last. I think it was about how everybody, there's 10 care managers for every client, and the insurance company has a care manager, the hospital, the community organization, everybody's got a care coordinator. A lot of that speaks to the lack of trust among the various aspects of the systems. And finally, last thing I want to say, and again, I say this in the best spirit of seeing in this room, now that the lights are out, some of the most remarkable incredible colleagues that anybody could have in this field. I see Kate McAvoy, who was our Medicaid director from our State Department of Social Services, members of our legal community, my inspired colleagues at CCCI, who are the reason why I get up in the morning. I see Tim from Qualidime, Tim Elwell and his staff from Qualidime, Jill, Fran. Despite that, I'm gonna say something that I feel in my heart and soul. We have a lack of unbiased, inspired leadership in Connecticut. Unbiased provider, senior level inspired leadership. People are, for the most part, representing their own organizations, their own piece of the healthcare system, the state agencies, their own organizations. And so raising this dialogue to a higher level is an extraordinary challenge for all of us. Thank you. Thank you.
Lawrence, go ahead. Molly said everything I was gonna say. I'm like,
and we even practiced.
I know. Check that off. No, so.
I'm sorry. The virtue of going first.
I know, Molly, you knocked it out of the park there. Good morning. My name is Lawrence Young, and I work at St. Francis Hospital and Medical Center at the Curtis D. Robinson Center for Health Equity. It's a very interesting place because we get to we have the luxury, some people call it a gift, a curse, but we all find it a great place to sit between the hospital and directly with the community. And so I think a lot of it was mentioned about how upper level management, hospital leadership doesn't really reflect a lot of the community ideas and concepts. We get to sit right in the middle of that. So we get to hear the beauty that what the community has to say, and we get to hear the wonderful things that the hospital had to say. And I use wonderful relative, But so what do we do at our center? Primarily our tagline is bridge, navigate, and support. We try to be that bridge between the community and the actual services that the hospital offer. We help work with community organizations to promote and strengthen some of their services, and that's the biggest thing. A lot of great things are happening in Connecticut. A lot of great work. Garden Street is not far from St. Francis at all.
I know.
Mary, I'm sure has some relationship with St. Francis, but knowing about the work Molly does, that navigation, that help, we can guide. We try to work together to guide people directly to those services, if and when we can. But I mean, we started out with a small prostate cancer initiative. We had a board member who was a prostate cancer survivor and saw the disparities among African American men. That's where it started. And men were dying. They had worse morbidity, mortality rates in prostate cancer. So we took a platform to kind of work and function with that. We've now expanded to a full Center for Health Equity, where we do things. We work with our diabetes center, colorectal screenings, breast cancer, health fairs, obesity, health education. I sat and wrote this down last night, so I'm going to read it and get through it. Academic partnerships, research, different community partnerships, and we also do a diversity, inclusiveness, and cultural competency training with different hospital level personnel and also different organizations within Hartford. And our goals at the center are really education, engagement, health advocacy, and research. And one thing about us that typically, we're very unique because a lot of Centers for Health Equity are partnered with research institutions. A lot of, across the country, a lot of big universities have Centers for Health Equities where you have professors that are doing amazing work, get together, who focus on health disparities, and it could be anything from childhood obesity to cancer to HIV. They cluster these professors together and they're able to collaborate and work on different initiatives. We answer directly to a hospital. So we have the beauty of kind of defining that for ourselves. And when we do research, it really is, it's writing papers is great, getting grant funding is great, but we really want to use the research that we do to really lead to an improvement of the services that the community offers and that the community receives. One particular story that stuck out, I actually led a study with African American men in primary care. And it was just a simple qualitative study where we wanted to find 30 men at random throughout our clinics at St. Francis. And we wanted to know what are some of the barriers, some of the enablers, what are the factors, basically when you go out and when you seek a doctor. We see many of these amazing models that are great. They deal with the care coordination, care navigation, different insurance plan, what happens. But I mean, honestly, I'm not going to ask people, but I know I can't tell you about my insurance plan. I have issues, limitations. I've gotten outrageous co-payments, and people who know me personally know I've been very upset a few times going to get a simple physical or a simple tooth cleaning. So let alone people who are in underserved communities and populations, explain that care plan. And we also, St. Francis has a high emergency department or emergency room utilization among people in the community. Definitely, Mary, I definitely saw that line where a lot of people in the community go to the ED for their primary care. Right. So we wanted to know what was going on with African American men who have very, as an African American man, if I could take my right arm, I might want to become a white woman because I would have better health outcomes as just call a thing a thing, okay? As an African American man, we have some rough stuff going on. So, we wanted to really focus on this population and really understand how to kind of better what's going on when they seek primary care. And we found some really great things dealing with what happens when they go seek a doctor, what happens when they go to the clinics. Doctors change frequently. But one thing that I really like about doing research for our center is that, like I said, research and publications, that's a great thing, but we really want to focus on the community. If somebody comes to our center with a need, or especially a health need, we do what we can to navigate them. Out of the 30 men, 12 of them got directly into primary care. There was in the brief I conducted the interviews. In that interview process, a man revealed to me that he was suffering from hepatitis for 2 years that had gone untreated. And because we have a nurse navigator on our team, and we have a medical director that runs our clinic at our hospital, we were able to get him care, get him treatment, and also follow up with him to make sure he had a doctor. And one thing that he said that kind of stuck with me and really changed the course of the study, he said, well, it's easier, I go to the ER for my blood pressure medication when I have a headache, but I said, well, you don't talk to them about your hepatitis? Well, no, I don't feel comfortable telling him that. So even though having a doctor, having the relationship with the primary care provider is something that a lot of people in our population that, that they don't have that. So we really try to work with that and really, pull it together with that. So I'm going to just, Molly, you could have given Molly a couple of extra minutes. I'm going to move on.
Thank you.
Thank you.
Thank you.
Good job.
Good morning. My name is Yolanda Lopez, and I am a lead care coordinator at Clifford Beers Clinic for our wraparound New Haven program. And this is a brand new initiative for Clifford Beers, but a little bit about our organization. We've been doing mental health services for children in the greater New Haven community for over a century. And so look at Clifford Beers like two avenues who interact and connect very frequently, where we provide support and for social work, but we also do the therapy and clinical perspective. So, Molly, I sat when you started your message. I just have to say that we can probably have the rest of the day to really have conversations about the families that we all serve directly. And I've had a lot of experience doing that, but just to talk to you about our program and what we hope to do and what Clifford Beers has been for many years really focusing on trauma and how trauma really impacts our families. And our clients share with us a number of times how they have more than 3 experiences of trauma. And data is very popular in stating that most of those traumas are based on losing a loved one and not really following through with care and outreaching and trying to really cross the gap of social impact and outcomes in our community. So, most recently, it's been a century, so we've done a lot. We've done from that direct outpatient service therapy to now really looking at wraparound New Haven. Another initiative we have is the Trauma Coalition, where we go into schools and do care coordination. And really, we realize families don't come to our clinic because they have the challenges of transportation. So how do we go to them? So reaching out where the children are in the school setting. So wraparound New Haven is similar. We go into the home. It's in-home services every week to meet with families with similar challenges of what Molly has shared, but we're integrating that care. So we're looking at behavioral health and we're looking at medical care in general, right? So how children get enrolled or families get enrolled in our program. I'll tell you briefly of our criteria because I really don't want Jill to give me the wrap it up. And I can really talk a lot, so I know that I have to look on time. So the reality of the situation is we look at children who are high utilizers of ED and high hospitalizations. And we're, basically looking at enrolling them into the program and then working with the entire family, which I think we're tasked with a huge responsibility when we talk about care coordination. Our care coordinators go in the home to look and talk about a child, but realize a lot of what Molly has shared, housing issues, basic needs, just basic need, food, utilities being turned on, turned off, and how, really focusing on that crisis before we can even look at how do we deal with your health care and how do we contact your providers, whether it's a specialty doctor or whether it's a primary care doctor. So we're trying to create this linkage and really meeting families where they are. I think I can't say that more than anything. You really go into a home, there is no what do we call it in the office, cookie cutter process? It does not exist in our population. I think every family is different. So really just going in there and developing, so we use the wraparound model, Milwaukee model, to do this. So we look at family strengths and really look at what their individual needs are. We're not telling them what to do, but tell us how we can help. And that's our approach. So when you hear about Wraparound New Haven throughout the state, I think you should really look at us as not only empowering families, but really educating in them and showing the engagement process that you talked about our, African American males. And how do we give them those tools to really make this happen is through a care coordination. We're very different. I've been in a number of places really promoting our program, and a lot of people say, so what is different from Wraparound New Haven from, care coordination and other programs? And I think with us, it's just that we work with the entire family. It is a CMS grant that we receive, so we're tasked with a limited time to really implement some integration of care. So I think that if we think of our families in our communities, and we always say, let the family drive the process. I can't say that enough. I think that, take that message, and then I'm not even going to go into the aspect of our leaders in the state. I've been around for many years to know that, Connecticut is challenged with, having a lot of shifts in different areas. We can talk about early education, which I have a background in being in Head Start from the bottom up. But just really looking at how do we meet the families where they are. And my heart goes out to Mary. I'll share a brief story just to really lead into the perspective of the child and what children go through in our communities. When you talk about a young man who's 11 years old, that has a mental capacity of a 5-year-old and is being bullied in his neighborhood by other children of his age, and the family, the mom who's currently pregnant and have a whole bunch of medical conditions going on, has to deal with being informed by the school that this was videotaped and that the child was beat up a number of times. And she's like, oh no, it's just kids, and not really understanding that because of a language barrier and the dynamics behind it. That takes to heart as workers, right? So how do we empower this family to really move forward and say, you need to not only look at the legal part, because the other side for me is what's going on in those other children's minds and what's happening to those other children that are being traumatized to do this to a child of their age. So there's a lot of dynamics that we can talk about, but I do want to be consequent to the time and just share that it's not easy work. So if you wonder why it's not happening, it's because it's not easy work. And we have a lot of layers of needs. It's not just healthcare when we go into a home. I mean, I'll stop there because then I'll go into another mode.
Well, you gave me a great place to start, and I first have to say thanks for everybody for being here. I'm totally humbled to be on this panel with everybody, and obviously with the folks here in the room. And I think, what you just said is kind of the essence of what Community Solutions kind of tries to think about is, it is not actually the particular health concern that folks are thinking about in their life. It is everything else before that, and not the diabetes medication. And so, I think what we need to think about as folks in this room is what are we doing to clear that path? And is that really working? What are the key things that we're doing? How can we check our egos at the door? And how can we clear that path so that people can really live their lives to the fullest potential? And like you said, there's not a cookie cutter approach, but there is an opportunity to come together, I think, in a meaningful way with the right players. I think the players are poised. St. Francis has been very interested. We've been doing fantastic work with them. We've been talking to Molly. I mean, there are folks here that are all willing to do it. And I think with the state, wanting to come to the table. I think that what we're doing is we're kind of like, it's like herding cats, or I'm not quite sure how to like explain it in a way, but what we're trying to do is clear a path for these folks. It is no mistake that my office abuts Garden Street, so I probably know Mary. I think what we need to remember is that that this is going to require immense amount of thinking at the systems level, at working between state agencies to see what really are these bottlenecks, and then what can we do, both as community-based organizations, as institutions that are important in the community, as folks who are giving at the care level, to remove those barriers quickly and identify them and then fix them. And I think that's where we're going to see the greatest movement for Connecticut. And I'm very excited that we'll be able to hopefully look at some of the resources that have recently come to our state to be able to kind of think about those things.
Great, thank you.
And I got no 2-minute card.